Okay, so today my presentation is about the potential of procalcitonin. This is a diagnostic marker that we use today in today's bacterial infections, kind of to see if they have one, if it's elevated, and to see if it correlates with a bacterial infection and how useful is it. So I just wanted to do a quick overview of that. So here we go. Okay, so here is our learning objectives, just a few of them. So I just kind of want to go back over what procalcitonin is and its properties, kind of just explain of what actually procalcitonin is. And then the trial that I looked into is looking into more of the pediatric side, which is relevant for this rotation, and to see how efficacious it is in antibiotic stewardship, if we should use antibiotics and how long, and does it make a difference if we look at procalcitonin or not when deciding to DC antibiotics or to initiate them. And then just discuss procalcitonin as a whole and its potential role as a diagnostic. Okay, so what is procalcitonin? So procalcitonin is the precursor of calcitonin. Procalcitonin is a 114 amino acid peptide precursor of the hormone calcitonin, and calcitonin is that hormone that's involved in regulation of calcium and calcium homeostasis. And procalcitonin is actually produced by parafollicular cells of the thyroid and by neuroendocrine cells of the lung and intestine. Usually it is found in other cells, but it's really suppressed and not above the level of it's below the level of detection in other cells. So where you see them are these neuroendocrine cells, and you see them whenever there's inflammation going on or some type of infection, particularly bacterial infection. There's been studies showing that they actually don't go up as high during viral infections, but during bacterial infections. So that's what kind of makes them unique to using them for antibiotics, because they kind of are upregulated during a bacterial infection. So like I said, they're normally below the limit of detection, but whenever you do have a bacterial infection, there is their gene expression is upregulated, and so you have known triggers that cause this for upregulation of procalcitonin, and those include bacterial toxins, pro-inflammatory cytokines, and some of those cytokines include interleukin-6, interleukin-1 beta, tumor necrosis factor alpha, and also lipopolysaccharide from gram-negative bacteria. So kind of those inflammatory markers, and then things given off from bacteria. And so this expression is upregulated, and you see increased serum levels in the blood of procalcitonin, and that's where you get the idea of measuring procalcitonin during a bacterial infection to see if it's actually upregulated, and see if a bacterial infection is actually taking place. So like I mentioned, because of these properties, of procalcitonin and its upregulation during bacterial infections specifically. It is used commonly as a diagnostic to determine if and how severe a bacterial infection is. And so I looked into a study that deals with pediatrics and preterm infants, and to see how effective using procalcitonin is on these premature patients, and if the duration of antibiotic therapy was lower, or if there was any worse events that happened that didn't use the procalcitonin approach. So that's on my next slide. Here we go. Okay, so this is the study I looked at. This is a procalcitonin guided decision making for duration of antibiotic therapy in neonates with suspected early onset sepsis, and it's a multi-center randomized controlled trial. And these are what we see a lot on this rotation. These neonates that are treated for early onset sepsis, and I remember seeing this during rotation, so I thought it was pretty relevant, so I wanted to look into this trial to see how procalcitonin really affected these patients, if it was positive, negative, and see if it actually helped or not. Okay, so they were saying up to 7% of even term and late preterm neonates in high-income countries receive antibiotics during the first 3 days of life because of suspected early onset sepsis. The prevalence of culture-proven early onset sepsis is 0.1% or less in high-income countries. So that suggests substantial overtreatment. So it's up to 7% of these neonates that are getting these antibiotics, but the ones that actually have a culture that proves that they have sepsis is 0.1% or less in high-income countries, which would be us. And so it does suggest that we overtreat this. So in this trial, they're looking at procalcitonin and to see if that can be used to safely reduce the duration of antibiotic treatment and the overall use of antibiotics, that antibiotic stewardship that we stress a lot these days. So that's your background. So as far as the methods, it was a randomized controlled trial, but they were centers in Dutch, Swiss, Canadian, Czech hospitals, and the number is pretty low too. So that's a weakness of this trial. They did include neonates of gestational age of 34 weeks or older. We do see a lot of preemies less with a gestational age lower than that, but they chose 34 weeks and older, and they had suspected early onset sepsis requiring antibiotic treatment. And so they were randomized and either using to the different groups of either using procalcitonin guided decision making or standard care based antibiotic treatment. Okay, so here are the results. As far as the procalcitonin guided decision making group, we did see a significant reduction in these infants as far regarding their duration of antibiotic therapy. I think it was a difference between less than 9.9 hours between the procalcitonin group and the standard group, and also there is no difference between reinfection and the procalcitonin group and the standard care group. But one limitation of that was there wasn't enough patients included to say that was statistically significant. So this trial definitely needs more patients before we can have like a final say that this is definitive. And I put the more of the details in the slide as well, as you can see. But overall, it did reduce the duration of antibiotic therapy in the procalcitonin guided decision making group. So as far as their conclusion, they did conclude that using procalcitonin guided decision making was superior to standard care in reducing antibiotic therapy and neonates with suspected early onset sepsis. Like I was saying earlier, non-inferiority for reinfection or death cannot be shown due to the low occurrence of reinfection or an absence of study-related death. So that's where we can include a larger population size and assess that as well. They did say procalcitonin seems to be the best intervention to reduce duration of antibiotic treatment in neonates suspected of early onset sepsis, because procalcitonin has the highest negative predictive value of all established biomarkers for infection. As far as my conclusion, I do believe procalcitonin could be an effective marker to decide if we need antibiotics or if we need to DC the antibiotics. But I do not think this should be like the sole factor that we look at to make this decision. Of course, I think we should bring in all the other things that are associated with the patient, what they look like, what their other lab levels are like, WBC, their Kim panel, and all of those should be collectively looked at before making any sole decision on procalcitonin. But I do believe procalcitonin does have its use regarding antibiotic therapy and how severe a bacterial infection is, and also the presence of a bacterial infection. So for my conclusion, I do think that it is a useful biomarker. Further studies should be done to look more into this procalcitonin, and especially in pediatrics. It might not differ among the adults, but as far as whenever I was looking for procalcitonin studies, there was only a few that were dealing with pediatrics. So I'd like to see more studies in that population.